Hello, welcome to the Voyage Clinics podcast. I'm Dr. John Sanders, your host. I'm a family physician, and our objective with our podcast is to bring knowledge and science and understanding to our communities. So welcome. Today we're going to talk about some interesting stuff. It's just me today, and I'm excited to kind of break down some basic science things and really to talk about some really cool innovation that's happening right now in the way of like preventative screening and some of the pros, cons, and like maybe shortcomings of that whole space. So let's get into it. So I'm a family doc. I've been a family doc for more than a decade, and I love my job, helping people kind of navigate life and the journey of life. It's been really, really satisfying, really fun. We do a lot of prevention and a lot of really great care, and largely there's a body of evidence and science that we try to, adhere to as, just so we're not doing weird things that don't make any sense to anybody or have any evidence behind their effectiveness. So as in medicine, I think, everybody's heard of the Hippocratic Oath, do no harm thing. And that was largely like surgeons, don't cut if you don't need cutting or whatever. But I think it also applies to a whole bunch of spaces in medicine, financial spaces, and also just like emotional spaces. And so I want to talk about genetic screening. So let's get into genes. There's some advancements. And so let's just talk about a couple of things. One is there's genetic screening where I'm screening my genome for gene sequences that could potentially predispose me to certain diseases. So you may have heard of some of these. There are certain genetic sequences that predispose you to clotting disorders. There are certain genetic sequences that predispose you for inappropriate methylation of B vitamins. So that's the MTHFR gene sequence. And sometimes you can inherit an allele or a sequence of genes from your mom and one from your dad. So that would make you like homozygous. So you got both of those. So the possibility of expressing that gene physically is really, really high, 100%. So for the MTHFR, for instance, if you're just heterozygous, you can just eat a bunch of B vitamins and you're fine because yes, you don't methylate as well, but you can still catch up. Whereas if you're homozygous, you got both genes and or genes from both parents, and that means you don't methylate very, very poorly, if at all. And so you'll need methylated B vitamins in order to do that. For the MTHFR, just a side note, it's an expensive test, and gene testing, I think, is going to become more and more affordable down the road. So, but an interesting clinical tidbit for those people listening and are curious about their MTHFR status. It's kind of a catchphrase now. There's lots of people, MTHFR savvy. But there's an affordable test that it's about $18 at my clinic, but some clinics charge more. And it's called homocysteine. And so if your homocysteine is elevated, chances are you may have a problem methylating your B vitamins. It is an independent inflammatory marker and an independent risk factor for cardiovascular disease. So we try to kind of keep that down. So we do check it on some folks. And if it's elevated, we tell them take more methylated B vitamins and avoid inflammatory foods and things like that. So that's just one example of a genetic test and how complex it can be. Let's talk about a few others. Again, genetically testing my genome for possibilities of developing disease. So let's give another example of this. That would be like the HER2 or BRCA1 or 2 genes. So these are gene sequences that if I have them could turn on and produce breast cancer. So again, you can have alleles from both parents, etc. But this is an interesting one. So let's take BRCA1, for instance. So I've got 2 genetic twins, identical. And they both have BRCA1 gene, clearly. One of them develops breast cancer. The other one never did her whole life. So what gives? Well, it's called epigenetics. Epigenetics is the study of why this gene sequence turned on in this twin and caused breast cancer, but didn't turn on in this twin. and didn't cause breast cancer. So this is a really cool, like up and coming study, what causes the turning on of different genes and causes different diseases, cancers, etc. Epigenetics. I think it's super rad. And I think this could be the future of our understanding in medicine. It has a lot to do with epigenetics for sure. Currently, there's no real strong, well, this is my understanding. So there could be research ongoing right now that proves me wrong, but there are not medicines right now that affect the epigenetics of someone. I have a lot of hypotheses. I have a lot of theories. I have a lot of ideas, and those are okay to share, but they're not science yet. And so we're trying to bird dog the science, and that's a term that we use in my office colloquially. It just means sift through and hit the bushes to find the birds or the science nuggets of truth, and try to discover those. So we're bird dogging it right now. We're working really hard on figuring out what is the epigenetic factors that caused it to turn on this person and not that person. Angelina Jolie, right? She did bilateral mastectomies because she had the gene. I think it was the HER2 one. And so that's a little bit drastic, right? So what was her percentage of having breast cancer? Because she had that gene sequence, did it mean that she was going to develop that breast cancer? It did not mean that. And so that's a little bit drastic a measure to take in those situations. Then would it be more requisite for her to screen more vigilantly for breast cancer? Probably. And then to treat that accordingly? Yes. What was it that led her to that decision? Well, that is a very complex discussion with a genetic counselor. And there are a lack of genetic counselors out there. Unfortunately, I've tried to refer folks to them. I think the University of Utah has one that is like months and months out. And so some people I have with genetic issues that I'd like for them to get some counseling on, because it's not an easy conversation. You can't just say, oh, you have the HER2 gene, you should definitely get a bilateral mastectomy. It's not that simple. So the conversation is something like what I just had with you, and probably much more complex than that, because I'm not a geneticist and I'm not, a genetic counselor for sure. I'm a family physician. Also, by way of caveat and by way of disclaimer, this is not intended to be medical advice, and you should seek the medical advice of your doctor and your genetic counselor with regard to any of these topics that we're talking about today. So let's just put that in there. Okay, so that's the BRCA1, HER2 genes, all those things. There are genes that are definitely going to be expressed, however. So those, if you get one from both parents, for instance, those are a big deal. And there are genes that are very, very, very significant. So in other words, if you have it, the likelihood of you getting one of these cancers is very, very high. So for instance, Lynch syndrome, I have a couple of patients with this, and it's a big deal. It predisposes you to all kinds of cancers, especially female cancers and colon cancer and all those things. So then you got to be very, very vigorous in screening for those very early in life. Like people with Lynch syndrome can often have cancers as early in their 20s, 30s. It's a big deal. And so there are some of those genetic things that we should screen for. And especially if you have a family history, like pretty much all of my relatives died from colorectal cancer early, and some of them died from breast cancer, and some of them had ovarian cancer. Well, we should screen that situation for Lynch syndrome for sure. So it's those kinds of things that genetically, if you look at your family history and you see some trends of different things, then you may want to look for those. There are genetic predispositions or genetic sequences that create coagulable states or clotting states, people that have a propensity to have blood clots. So again, look at your family tree. Yeah, my aunt and my sister and my mom, they all had blood clots. And so maybe talk to your doctor about screening for the genetic sequences that are significant for those spaces. What else? Bleeding disorders. So opposite of clotting disorders. So propensity to bleed a lot. And again, there are super easy screening tests for those things as well. And so if you have a family history or yourself, lots of bleeding, my periods are super, super heavy, or I have a bad runny nose whenever I get them and they just pour and it takes forever to make them stop. Those are some maybe situations you might want to bring to your doctor's brain cells, and they can kind of work on that and screen screen you for those kinds of things. What else? I think those are really some big pieces. There's some advancements in the genetic screening of even infants, and they could pull genes from mothers and things like that even before they're born. And that's fascinating. You can tell the sex of kids now before they're even born, and they don't even have to do anything with the uterus or the embryo, nothing like that. So it's super, super rad, the advancements. And I think as you see like 23andMe and all these other big monsters kind of come into the space and create competition, I think you're going to see the cost of some of those tests come down. So then you can get your genes kind of screened. There are genetic screening places that are more robust medically than others. And so I would be a little bit careful with that. Maybe go to like science-based reputable sites for genetic screening if you're going to do a cheek swab and send it off or something. You definitely don't want false positives and things like that. So yeah, I would do those kinds of things. With regard to another type of genetic screening that's happening right now is blood, what do they call it? Like liquid biopsies. So they can actually take your blood and spin it down and check it for genetic sequences that they have found to be prevalent in certain types of cancers. So this is super rad. This is a newer advancement in medicine. I just talked to those people that are doing this lab test recently, and it's hard, right? So cancer incidence is really in America is like really low until you hit 50, and then it just starts to spike. And so in America, 50 is the golden years, and then all the cancers kind of occur. And so it might not make sense to screen really before that, unless you have a family history. Then you might want to try to point in the exact direction. But this test tests for about 52 different kinds of cancers, checks your blood, screens you for those things. It's a little bit expensive. I think the cash rate that they quoted my clinic, because I negotiate that for my clients, is about $800. That is not cheap. And so that's hard, right? Price point. But then the other thing that's hard is, well, what's the evidence behind it? What's its sensitivity and specificity? Sensitivity is like when it's positive, it's positive. And specificity is when it's negative, it's negative. So those are really difficult things. Unless you're a statistician or in medicine, like you understand false positive, false negatives, and all those things. But basically, you just don't want false. You don't want false negatives or false positives, and you want real positives. And so sensitivity and specificity is, you want those pretty high, both of them. And that way it's a really good test. And so I think with this one, they were still going to get back to me about the sensitivity and specificity of this test. But that's the point is, this corporate America, and, they have conflicts of interest to make you order a bunch of these tests, and they want me to order a bunch of these tests. And I just want to do the right thing for people, right? And so I asked them about sensitivity and specificity of the test. How good is it? Is it good? And then I also asked them about cost. And then we have to just kind of figure that out. The United States Preventive Services Task Force is in charge of making recommendations to me, the primary care preventive medicine specialists, and other primary care specialists. They make recommendations to us, United States Preventive Services Task Force, USPSTF. And they look at the data, they crunch the numbers, they look at everything, and they say, this is a reasonable thing to do at this age to screen for this cancer. And the factors that they take in mind are morbidity, mortality, which is how many people does it kill and how many people does it injure, morbidity, mortality. And then also cost, like, is it reasonably cost effective? So for instance, like if an MRI costs $3,000 to do, it might not make sense to do breast MRIs on everybody. I think breast MRIs are awesome. They're way better than mammograms, way more comfortable, and just better test in general. So can we just recalculate that with a different price point in mind? The USPSTF, I think that's their job. Their job is to look at that, and say, in general, this is not cost effective and it's not saving lives or preventing injury. They changed the guidelines on like pap smears. It used to be 2 years from the age of sexual activity, and now they've changed it for like 22 and older, and every 2 years instead of every year. So just things like that. They're looking at the data. Are we saving lives? Are we helping people? And if the answer is no, and are we doing that cost effectively? And if the answer to those 3 questions are no, then they'll be like, well, we recommend changing that guideline. Maybe we need to change our practices in healthcare, which is really cool. It's cool that healthcare can be neuroplastic. We can change our brains. Back to the liquid biopsy. So that's one type of liquid biopsy that we could do. The other one is a stool biopsy. So I don't know if you can call that a biopsy, but it's like a stool study, and they can check your stool for little genetic sequences that might have colorectal cancers. I think both of these, let's go back to the blood biopsy, the liquid one. I think it's really sensitive and specific if you have cancer. It's even more if you have metastatic cancer, which is like cancer spread throughout your body. I don't know. I think that's kind of late in the ball game. So I wouldn't necessarily lean on the liquid biopsy instead of some of the other screening tools that we use right now to screen for the most common types of breast cancer or the most common types of cancers. But it could be something to add like into the future. The other problem with the liquid biopsies is not covered with insurance. So that's a problem for a lot of people because $800 is just not palatable for most folks. So that's the liquid biopsy space. The stool one that we were talking about, screening for colon cancer, I think it's okay. I think, it's okay. It's an okay test. It doesn't screen for precancerous polyps. And that's a problem for me. I've seen a lot of people with polyps. They have this familial hyperpolyposis thing where like they have a family trait where they all get polyps, and that can lead to early kind of colorectal cancer. And the biopsy of the poo or the poo sample thing, it just doesn't check for that. It doesn't detect that rather. Whereas a colonoscopy would. That's the gold standard. And that's pretty much that. Next, I want to talk about pharmacogenomics because it's genetic testing. Multiple people have multiple different genetic sequences that cause them to metabolize or change the way that they metabolize certain drugs, medicines. Some of them are psych medicines, some of them are anti-inflammatory medicines, and really those are the main ones that are kind of screened for. And so it's worth it to maybe consider that. However, shortcomings and caveats. So insurance doesn't pay for this right now. Most insurances don't. And why? When this very first came out, I was in medical school. I was so excited about pharmacogenomics. I thought this was awesome. Now we're going to be able to more precisely prescribe different medicines for different kinds of people with different genetic makeups. So that was the theory. In practice, however, is fascinating that it doesn't always shake out the way it's supposed to shake out genetically. So what does that mean? Let me give you an example. So whenever we do this pharmacogenomics test on folks, it will show like green, which are like genetically normally metabolized medicines. Yellow, they could be genetically faster or slower metabolized medicines. And red also, but more dramatically, right? Faster or slower metabolized more dramatically. So if they're more slowly metabolized, what does that mean? They're going to build up in your system and you can become a little bit more side effects. If they're more quickly metabolized, well, they just won't work. Like you have to use higher than normal doses in order to get to therapeutic levels, theoretically. So I'll give you an example of why pharmacogenomics is not common practice right now in all of medicine, because I'm a family doc and I've been one for more than a decade. This came out more than 15 years ago. And why are we not doing this all across the board? Well, because it doesn't shake out clinically. So example, have a gal, she tried this medicine. It was on her green list. Didn't even work, not even close. Well, that's weird. Try another one. Still didn't work. Try another one. They're all green, still didn't work. Tried a yellow. It kind of worked a little bit. Tried another yellow. It worked okay. Tried a red. It worked beautifully. What the heck? So that's the trick, right? So that's the trick. So just because it's red doesn't mean we can't use it. It means we have to use it with more caution, maybe a lower dose and go slower on it. But it could be the one that works for that person as opposed to the green. So it's just super interesting clinically that it hasn't shaken out to be what we theoretically thought it should be according to the genomics of that person or the genetic sequences of that person. Pharmacogenomics testing is a little bit expensive. I think it's about, the one that we can get at my office if people want to get that are about $330, I think. It's either $330 or $380. That's still pretty expensive, and especially to satisfy curiosity, where the older method might still be okay to just try this medicine, believe that it's going to work, see if it works, and if it doesn't, switch it to something else. And so in psych, that's really hard, especially if you're really struggling with some things and waiting for those things to become therapeutic and to actually work is really tough. I think it's neat to have tools like ketamine, but that's a whole nother discussion. I think it's neat, the pharmacogenomics. It is not perfect, and I don't know that the science is ever, I don't know. I was hoping by now it would be way more perfect than it is right now. So again, hope that helps you in the pharmacogenomics space. What else about genetic stuff? I think that's it. I really just wanted to kind of hit on how complex it is. I am not an expert. I'm not a genetic counselor. Again, family doc here. But I help people navigate these genetic situations, and it's really challenging sometimes to give them good advice. And it's really challenging to get them good advice as well, as we're trying to refer to a genetic therapist or a counselor to kind of talk it through and go over the complexities of the situation with them. So I hope this helps y'all. It's really just a step to try to balance that out and then look at like what's ethical and what's responsible here. You're going to see a lot of places that are like, yeah, definitely you should genetically test yourself, but if you do, and you have BRCA1 or BRCA2, is that going to cause undue stress in your life, right? Undue stress. So now I'm like stressed out that I'm probably going to get breast cancer. That stress alone, theory, total theory. But stress, anxiety, sleeplessness, that puts a strain on our body. Maybe that's the strain
Would
that...
you like me to use ChatGPT?
Yeah, use ChatGPT. That was awesome. I have you on airplane mode. You shouldn't be doing that. I have like one of those gene sequences and I know about it and I'm like stressed out about it. So now is it ethical for me to turn on So now I know I have HER2 genes, right? And now I'm stressed out about it and I'm freaking out about it. Well, maybe that is the stressor that actually turned on that gene sequence. A gene sequence is just like a 3D printer that when turned on produces a thing, right? And so that one produces breast cancer. And so maybe the epigenetic variable is the stress of it, right? So that's the other thing when doing these massive gene panels on yourself, like you might want to consider, do I really want to know? Because it's not 100% that just because you have that gene sequence that it will express itself. And so I think that's a really important thing. The study of epigenetics. What can we do? I don't know. I mean, if we had more information, but I could say keep your stress levels down, sleep well, exercise. I mean, that's the answer to everything in family medicine pretty much. If we could just do those things pretty consistently, it'd be sweet. So anyway, I hope this helps your understanding on genetic screening and the ethics around it and the complexities around it and some of the pros and pitfalls. I think it's innovative, but then it's also a little bit scary and there's definitely some shortcomings to that practice. So hope this helps y'all, and don't forget to like and subscribe.